Good morning. Today's class, we talk about the disorders affecting the trigeminal nerve. The disorders can be broadly classified into two groups, one that causes injuries, or one that is due to injuries, and one that is due to the neuralgia that affects the trigeminal nerve. The causes of injuries, common causes are third molar removal or lower third molar odentectomy, facial trauma and its management, especially when we have a laceration to the lip or a fracture of the angle of the mandible, the inferior alveolar nerve or mental nerve can be injured. And the management itself, when we apply plates and screws, that is the when we do an open reduction and fixation, these screw endings can pierce into the inferior alveolar canal. Orthognathic surgery, obviously, when we do a bilateral sagittal split or osteotomy, when we split the mandible, the body of the mandible into in the sagittal plane, into the buccal and the lingual cortex, and put it back with plates and screws once the movement is achieved. All these can have a direct effect on the inferior alveolar nerve that lies inside in the narrow space, and it can get inadvertently injured or even cut completely. Dental implants posterior to the mental foramen, the inferior alveolar nerve can be affected when we're not careful in putting implants, and in the maxilla, in the anterior incisor regions, can injure the branch from the incisive canal. Salivary duct and gland surgeries in the submandibular duct, surgery involving a stone, you can inadvertently injure the lingual nerve. Treatment of benign and malignant lesions of the head and neck. Any resection of soft tissue or even hard tissue can injure preprosthetic surgery and endodontic surgery, especially in the anterior of the upper or the lower. The incision and the whole treatment can give rise to numbness of the lip sometimes, which is again branches, the finer end branches of the trigeminal nerve. So in the third molar removal, what are the causes? Local anesthetic injection directly into the nerve or around the nerve, or piercing the nerve with the needle tip can cause injury. Incision and flap design, when you retract the lingual flap, that pressure of the flap and the instrument can cause injury to the lingual nerve. The use of high-speed drill for bone removal or tooth section. Elevation of the tooth with trauma to the lingual soft tissue. When you have a third molar, a lower third molar, which is rotated lingually, that is, the crown lies in the lingual space or the lingual side, and when we try and elevate the tooth after relieving the bone, obstructed bone, we tend to pressure. There is a tendency for pressure being applied to the lingual soft tissue if you're not careful, by causing lingual nerve damage. Socket curettage and exposed neurovascular tissue, especially dental follicle removal, and you remove a third molar, you can inadvertently catch with your mosquito forceps, you can catch the lingual vascular tissue containing nerve endings. Use of medicaments in the extraction site to aid healing or prevent osteitis. In earlier times, we used to use tetracycline compounds, which again can injure, or when it seeps inside the bone, can injure the nerve. Placement of sutures, if you're not careful, you can catch the nerve in the soft tissue. And when we tighten the thread, it can compress the nerve or even cut the nerve. Incidence of trigeminal nerve injury in the literature. From third molar surgery, the incidence range from 0.41 to 7.5%. As for third molar or impaction removal. In sagittal split osteotomy, The range is from 0.025 to 84.6%. So you can see a wide range. So it depends on the skill of the operator mostly. And if it's very high as 84.6, it is we should say that it is an unacceptable amount of side effect of the surgery. Incidence of lingual nerve injury from third molar surgery is about 11.5%. So risk factors of trigeminal nerve injury. What are the risks of the patient actually getting a nerve injury? At once, patient age, older age group, nerve injury, and even if a small damage or small injury occurs, chances of the nerve growing back is very limited. Female sex, for unknown reasons, are higher prone for long-term nerve injury. Depth of impaction obviously makes it more difficult, more chances of injury. Mesiodistal angulation of the tooth, that is in a distoangular impaction of third molar, which is the most difficult sometimes to remove. The chances of nerve injury is higher. Lingual angulation of the tooth, like I said in the previous slide, the chances of the crown actually pressing against the lingual soft tissue or the pressure of elevation causing injury to the nerve, which lies inside the lingual soft tissue, is very high. Integrity of the lingual cortex, if the cortex is fractured, chances of nerve injury is higher. The need for tooth sectioning, if you're not careful when you section it, the burr tip can go beyond the circumference of the crown and enter into the soft tissue, and which area we will not be able to see from the buccal side. So that can be a disaster, ending up with the lingual nerve being cut. Removal of bone distal to the third molar, and the surgeon's experience, obviously. So there is a predictor which is available, which looks at IOPA X-ray and looking or OPG, and looking at that X-ray, we can predict the chances of a potential nerve injury to the inferior canal. So it's called the Roots radiographic predictor of potential tooth proximity to the inferior alveolar canal. So how we determine this, the root apex, which can be very close to the inferior alveolar canal in the third molar region. How we can determine whether this particular positioned tooth is close to the nerve or away from the nerve. So there are a few things that you look for in the X-ray. If there is a darkening of the root, there is a chance that that nerve, it will be lying close to that. Deflection of the root, sometimes as the root is being formed, if the nerve is in the way, then the nerve will not move away, but the forming root can be deflected, forming kind of a dilaceration. That means the root is very close to the canal and got deflected. Narrowing of the root, dark and bifid root apex. Root apex, if it is bifid, there is a high chance that the nerve lies in between the split. Interruption of the white line of the canal. Diversion of the canal. You look at the, sometimes very rarely, the canal itself can get diverted. And that is most likely caused due to a cyst which grows after the tooth is formed, like a dentigerous cyst, and that can pressure or press the canal away from the tooth. So actually a diversion of the canal can occur. Narrowing of the canal is also one of the signs. So edema from direct neurotrauma responsible for the paresthesia that resolves spontaneously. So the direct neurotrauma causes edema. So it doesn't need to actually have the nerve cut or section. It's just the swelling due to the trauma, to the pressure of the instrument on top of the nerve, or the edema that is created when we do a surgery. If the nerve is lying very close by, that can cause paresthesia. But these resolve spontaneously. Local anesthetic toxicity may be responsible for prolonged paresthesia following a mandibular clap, especially if the solution is deposited within the confines of the epineural. Again, very likely chance where if you're not careful and if you do not aspirate before we inject, the needle tip can be lying inside the epineural, which can actually, as you press this or when you deposit the solution, it will balloon out the nerve or the epineural of the nerve and cause injury. That causes epineural hematoma when the needle pierces the nerve, the neurovascular bundle that surrounds the nerve is injured, and there is a hematoma formation. And resolution of that hematoma again can cause nerve or temporary or permanent nerve damage. The needle barb mechanism of injury, especially seen in the inferior alveolar block. When we insert the needle, we are supposed to hit the needle against the lingual or the medial surface of the ramus of the mandible. And that tells us where exactly the needle is. So we are supposed to touch or hit the bone, and then we retract and then deposit the solution. So because these needles are very sharp, even that slight amount of force of the needle tip hitting the bone will bend the tip of the needle, and that forms a hook, like a small hook-like area in the tip of the needle. And as you pull the needle out, it forms a barb, and that barb can, if it is very close to the nerve, can pull the nerve as the needle is removed from the tissue, and that can tear the nerve. So here we see a cross section of the nerve, and you can see the cross section of the nerve. You have an outer epineurum, which is covering the whole of the nerve bundle. And inside the outer epineurum, you have inner epineurum that covers small fascicles, or bundles of fascicles are covered by inner epineurum. Then you have a perineurium and an endoneurium that is inside a fascicle. Fascicle is that one fine nerve filament. And these fascicles are made up of Schwann cells, microscopy, Schwann cells, and inside the Schwann cell we have an axon. Okay, so this is an axon covered by multiple axons form a Schwann cell, and Schwann cells multiple forms a fascicle, and it is covered by endoneurium and perineurium around it, and inner epineurum and outer epineurum covers the whole thing. Again, different patterns of neurovascular patterns. You have a monofascicular, the whole of the epineural covers just one bundle. Oligofascicular, multiple bundles, and polyfascicular, numerous bundles. Here you see how an injury to the nerve can occur. So following nerve injury, many changes occur. Nerve healing involves both degeneration and regeneration. So if there is an injury, there is degeneration, obviously. And then there should be some kind of regeneration. And that the whole process is formed, cause the nerve to grow back. Nerve cell body responds with an increased metabolism, with an increased production of RNA and breakdown of this substance. So obviously, when there is an injury, immediately the mechanism, the body mechanism of breaking down and regrowing of the nerve occurs. So all these structures like RNA and this substance are all increased. At the site of the injury, there is edema and cellular debris. This causes proliferation of phagocytes and macrophages begins to clean the area. So when there is an injury, there is dead cells, and phagocytes and macrophages begins to clear the area of dead cells. Within days, there are axonal sprouts that extend from the proximal nerve stump, having as many as 50 collateral sprouts. So again, from the body at the cut end, the sprouts starts forming, axonal sprouts, small growth of the axon that hoping to replace the cut nerve. So there is proliferation and a high level of activity of the Schwann cell that is covering the axon. We saw the Schwann cell is the covering the cell, and the axon is that fine structure which is inside. So there is separate activity happening in the Schwann cell also. So there is a proliferation, a high level of activity of the Schwann cell, which begin to lay down new myelin for the new axon. So the new axon is being produced. We don't know which one is going to be the main axon which is going to replace. Multiple collateral sprouts have been formed, and at the same time, the Schwann cell is also functioning. It is breaking down, and new myelin are being laid for the Schwann cell. If it's a myelinated nerve. Nerve growth factors that influence the direction of the sprouting and guide the new axon into the newly formed myelin sheath, known as the bands of Bundt. So as this is formed, because we see multiple axonal sprouts, one particular axonal sprout needs to be determined, and it has to be guided into the new axon. Into the newly formed myelin sheath. So this myelin sheath has been formed, and the axon has to go right into this myelin sheath. That is determined by nerve growth factors. So during this process, now you see there is multiple sheaths are being produced, and this can cause what is known as neuroma. That is, only one axon is directly required, but the rest of the axon and the myelin sheath, all that can get clumped together and forms a physical lump or tiny nodule kind of structure. That is called a neuroma. And when it is a direct cut, like an amputation, this is called an amputation neuroma. And sometimes only the periphery of the nerve is injured. The inside is fine. The periphery forms, again, this kind of the breakdown and regrowth occurs and forms a neuroma in continuity. So the nerve is in continuity, and there is a little lumpy kind of structure that forms around the nerve. Sometimes you have a lateral exophytic neuroma. Only one side of the nerve is injured, and that area forms this neuroma kind of structure. And when this is lying close to, say, a bone, that can get attached to that periosteum of the bone. This exophytic neuroma can get attached to the periosteum. That can cause a lateral adhesive neuroma. So on the right side, we see the classification of nerve injuries. Now, nerve injuries can be classified broadly into two kinds of classification. One is called the Seddon's classification, the other is the Sunderland classification. Now, the Seddon classification is a very early classification, and it is much simpler than the Sunderland. Nerve injuries, they are classified into three. One is called the neuropraxia, axonotmesis, and neurotmesis. So we'll talk about each one. So neuropraxia, axonotmesis, and neurotmesis. So in the Sunderland, that is the neuropraxia is called the first degree nerve injury. Okay. So the first degree Sunderland is equal to the neuropraxia of the Seddons. In the microscope, under the microscope, what do you see? There's no axonal damage, there's no demyelination, there is no neuroma. So the axon is intact. There's just a compression. There's no demyelination. The myelin sheath is not injured, so there is no demyelination, no neuroma, just a compression. And what clinically ends up with a loss of sensation for a few days or weeks. There is a rapid recovery, and there is no need for any microsurgery or anything to be done. Just allow it to heal by itself. So that's neuropraxia. So AD, most of the time, we hope that when we remove a third molar teeth and there is a lingual nerve paresthesia, we hope it is a neuropraxia. This is the compression of the nerve. No actual damage. It will recover within a few days. The second classification, or the second part, that classification according to Seddon, is axonal emesis. Now that is equivalent to in the Sunderland second, third, and fourth degree. Now we see that in picture. So this is neuropraxia, first degree neuropraxia. The whole nerve is intact, no problem at all. In the axonal emesis, or second, third, and fourth, we find different levels at which the nerve injury is occurred. So here, in the second degree, we have the axon through the antennulae. The third degree through the antennulae. That is, just the axon is removed or cut. But here, the antennurium is cut, and the fourth degree, the perineurium, up to the perineurium is cut. So all that three levels are together called axonal emesis in the Seddon's classification. So in the histology, there is more axonal damage, demyelination, and possible neuroma. What we talked about earlier, all these demyelination and axonal damages occur. And clinically, we find there is a loss of sensation, slow, incomplete recovery, takes about weeks to months, because this axon has to be regrow and myelin sheath has to form, take some time. Possible microneurosurgery sometimes might be required. Okay, so the third type of the Seddons is called the neuroemesis, which in Sunderland is called the fifth degree nerve injury. And here there is a total cut. That is through the epineurin, there is a total separation of the nerve. So that is caused by severe axonal damage, epineural discontinuity, neuroma formation. Obviously, when the epineural discontinuity occurs, the nerve is separated, or that once one part of the nerve separates out from the other, and it is not connected physically. Until the epineurum is injured, the nerve was connected physically in one line from macroscopically. But here, when the epineurum is severed, it just flaps away, moves away. So here, the outcomes are clinically, if I have a loss of sensation, spontaneous recovery is unlikely. It doesn't work that way. Microneurosurgery is needed. We have to align the split ends together and hope the epineurum and suture the epineurum together with a fine needle and sutures, and hope that the axon pass through. So trigeminal nerve fibers can be alpha, beta, A alpha, A beta, A delta, or myelinated, and C, which is the unmyelinated. So all these four types of nerves fibers are present in the trigeminal, just to give you a perspective. So the A alpha fibers are the smallest, biggest, and it produces precision and fine touch. That is a function. A beta gives a proprioception. A delta is responsible for superficial, or the first pain that occurs, temperature sensation by A delta. And C, or the unmyelinated, mediates the deep or the second pain, the boring kind of boring, as in the dull ache and deep pain that we experience. That is mediated through the C fibers. So the trigeminal nerve may present a variety of signs and symptoms. The injury to the nerve. Non-painful anesthesia is one type, where there is no pain, complete loss of sensation. Painful anesthesia, sometimes there is loss of sensation, but pain might be there because it's mediated by different nerve. So that is anesthesia dolorosa. Allodynia is a pain from a non-painful stimulus, and hyperpathia is increased pain from a painful or non-painful stimulus. Just touching will cause pain in allodynia, and hyperpathia can be, even just touching or even pinching can cause increased pain. Okay. So we'll end here and we talk about the following. In the following classes, we'll talk about in detail.